Okay, we'll start my presentation today. So today my presentation is on approach to headache. My supervisor is Dr. Mashitah. Good morning to everyone. So headache is one of the most common presentation in to our ED. In ED, basically the approach to headache, we mainly focus on identifying patients at risk of rapid deterioration or morbidity or mortality, to identify high-risk headache syndromes and to provide appropriate headache therapy. So these are the main three focuses to any patient presenting to ED with headache. So headache is, we can classify headache into primary headache and also secondary headache. So primary headache is anything which is benign and they don't have any, it's not associated with any structural disease of the brain. Whereas secondary headache is anything that to do with underlying organic brain diseases. Okay. So usually the common primary headache, which is common to our population, is migraine type of headache, cluster headache, and tension type of headache. These are the three most common type of primary headaches. So chronic paroxysmal hemicrania is like is a type of headache which is continuous and it is chronic, which is almost present every day in people, and usually for example, it's a very chronic type of headache that present for at least about 6 months and with a pain-free period. And usually in chronic paroxysmal hemicrania, patient will have is a unilateral headache, throbbing pain, and also associated with pain over the eyes and one side of the head. So these are the most common type of primary headaches. Okay, sinus headache, tension, migraine, and cluster headache. So migraine is a disorder of recurrent attacks. The migraine can be with aura or without aura. So usually migraine headaches are a type of unilateral headache, and the quality will be throbbing or pulsating. Okay, so patients selalu describe migraine headache as a headache yang ada berdenyut. And then usually migraine is also associated with nausea, vomiting, photophobia or phonophobia during the attacks. And usually there are certain stressors to migraine, for example, like stress, menstruation, or any weather changes, any lifestyle disturbances, for example, lack of sleep or alcohol intakes. This can trigger migraine headaches. Tension headache, unlike migraine, tension headache, they are often bilateral, and it's a dull, non-throbbing headache. And usually, probably it is associated with some stressors as well, like workload or any stress. Cluster headache is also a type of unilateral severe headache. Cluster headache, it is localized to orbital or supraorbital or temporal pain. And accompanied by autonomic phenomena, it's lateral to the pain, for example, like ptosis, meiosis, lacrimation, conjunctival injection, nose block or rhinorrhea, and usually it can last from 15 to 180 minutes. So that was primary headache, and we move on to secondary headache where there is an organic underlying brain disease. So we can divide secondary headache into extracranial disorders, intracranial disorders, and systemic disorders. So for examples of extracranial disorders causing secondary headache is like glaucoma, acute angle closure glaucoma, any carotid or vertebral artery dissection, dental disorders, for example, like temporomandibular joint dysfunction. Other causes of intracranial disorders causing secondary headache is like your brain tumors or any other space-occupying lesions in your brain, TSF leak with low pressure headache, any type of hemorrhage, it can be subarachnoid, subdural, or intracerebral or extradural, any type of hemorrhage, idiopathic intracranial hypertension, infection, and then CNS infections like meningitis or any chemicals or carcinoma, obstructive hydrocephalus, and vascular disorders. Systemic disorders that can cause secondary headache is acute severe hypertension or fever, even bacteremias can cause secondary headache. I will explain on these secondary causes later. So usually our approach to patients with headache in ED, not all patients with headache requires investigation. So usually differentiation of primary from secondary cause is the key. So any patient comes to ED with headache, they have to know whether it is a primary type of headache or secondary cause. So, and also failure to recognize any serious cause, it can potentially lead to fatal complications. So mostly the important thing here is our history and also clinical examination. So how to identify low risk patients who come in with headache and you can actually discharge them safely. So patient presenting with a pre-existing headache history, meaning they already have a headache due to failure of standard treatment. And usually if low risk patients with headache, they will come with a headache pattern where there's no change to their headache pattern. There's no like worsening symptom or there's no new concerning symptom. No any focal neurological symptoms or sign associated with the headache, and usually the patient won't be having any high risk comorbidity. So this kind of patient, usually they do not require any routine neuroimaging like CT scan or anything. Okay, so the important thing to any patient presenting with headache, we need to identify the red flags of headache. So there are a few red flags that we need to remember to ask the patient and to examine the patient so that we don't miss out any life-threatening causes. For example, any patients presenting to ED with headache, we need to examine for any focal neurological signs. For example, if there's any limb or body weakness or any photophobia or any gait abnormalities. And then patients who comes in with papilloedema, which is associated with acute angle closure glaucoma, so or increased ICP. So papilloedema is a sign of increased intracranial pressure. So any increase in intracranial pressure, it can actually cause swelling of your, it will cause an increased pressure to your optic nerve, causing this tortuous retinal veins. Okay. I also look for any neck stiffness because this is a sign of meningismus where any patient with headache and they present with neck stiffness, likely they can be having meningitis. Or any patient who has an immunocompromised state, for example, patients who have cancers, patients who have HIV, they are more prone to develop CNS infection. So we have to also look for the underlying comorbidities. Any patient with sudden onset of worse headache in their patient's life. For example, this is called the thunderclap headache. Thunderclap headache is actually defined as any headache that reaches 7 out of 10 pain score in less than 1 minute. So that will be, they will describe it as one of the worst headache they have experienced in their life. So usually, thunderclap headache is actually either associated with subarachnoid hemorrhage or any aneurysm. So we need to ask for that. And then any headache after trauma and headache that works with exercise. Other signs of other red flags that we need to exclude are patient who presents with visual disturbances, jaw claudication, fever, weight loss, temporal artery tenderness, proximal myalgia. So usually this one is a symptom of giant cell arteritis or temporal arteritis, where your temporal artery, you can actually, if you palpate the temporal artery, it will be tender, and usually it is associated with jaw claudication and proximal myalgia, mainly over the neck area, shoulder, and your back area, also associated with visual disturbances. So giant cell arthritis actually is not really common, but it's quite common in older age elderly people, more than 50 years old. So yeah, and then any systemic symptoms, for example, fever or weight loss. So fever or weight loss, it can be associated with some CNS infection, for example, your cerebral abscess or weight loss can be associated with any neoplasm like cerebral tumors, which can be primary tumors or secondary tumors. Okay. And then ask also for any progressively worsening headache. It can also be a symptom of more complicated problems. Also ask for any visual disturbances like patient having red eyes or halos around the light. Okay. So these are the matching red flag findings with a cause for headache. So usually if patient having neurological symptoms like altered mental status, if they present with headache together with altered mental status or confusion or neurogenic weakness, this can be likely due to encephalitis or any brain hemorrhage like subdural hematoma, subarachnoid or intracerebral hemorrhage. If patient is immunocompromised, having HIV or cancer patient, they can have metastatic brain tumor or any CNS infection because they are immunocompromised, so they're likely to have CNS infections like encephalitis or meningitis. And any patient with meningismus, for example, the triad of meningitis like fever, headache, and neck stiffness, together with photophobia or vomiting, this can likely be meningitis. And meningismus is also a sign of subarachnoid hemorrhage or subdural empyema. Any patient with onset of headache after 50 years old. Okay, how to actually differentiate primary and secondary headache? If let's say patient is having primary headache, usually the primary headache, patients with primary headache, their headache usually resolve as they age. So usually when they age more, usually the headache will start to resolve. But if let's say any patient comes in at age of 50 or more with a new onset of headache, so this can be, this should raise a suspicion for any serious cause, for example, like giant cell arthritis or any tumors. Okay, thunderclap headache is often associated with subarachnoid hemorrhage or any brain aneurysm. Combination of fever, weight loss, visual disturbance, jaw claudication, temporal artery tenderness, and proximal myalgia is actually very classical for giant cell arthritis. Any systemic fever or weight loss, it can be due to sepsis or cancer. Okay. So these are the ones that I explained previously. These are the examples of emergency causes of your secondary headache. So as I said, any patient presenting with headache, we cannot take it lightly. So our history and your clinical examination must be wise. So for any patient presenting with headache, the most important thing to ask is the location of the headache, the duration, the severity, how severe is it? Is it one of the worsening, is progressively worsening pain, or is it the same dull throbbing pain, or and the onset, whether it is a sudden onset or gradual onset, the quality of the pain, any exacerbating or remitting factors, okay, and then the age at onset, whether it's a new onset of headache at more than 50 years old, then it should raise your suspicion for giant cell arthritis, or response to treatment. So usually, if primary headache, they quite well respond to over-counter pharmacy medication or any normal painkillers. So if let's say if it is a pain that doesn't resolve with treatment, then we should investigate more. So any patient coming in with headache, we also have to ask about any substance use disorder. For example, any patients using adrenergic agents, for example, cocaine, amphetamine, or methamphetamine, all this can increase the risk for intracerebral hemorrhage. And also ask for any family history of sudden death or aneurysm or any autosomal dominant polycystic kidney disease. So if the patient himself or herself having autosomal dominant polycystic kidney disease, or if the family is having this polycystic kidney disease, it can be associated with brain aneurysm. Also, other review of system, for example, any vomiting, that can associated with increased intracranial pressure, any associated fever to exclude CNS infection, and then also ask them about their visual symptoms, any red eyes or halos or blurring of vision. So usually if the patient has red eye or halos, they can be having acute angle closure glaucoma. Okay? And then any visual field deficit or diplopia or blurring of vision, which can be associated with idiopathic intracranial hypertension. So idiopathic intracranial hypertension is also known as pseudotumor cerebri. It occurs when the pressure inside the brain or inside the skull increase for no reason. And usually this idiopathic intracranial hypertension, it mimics the symptom of those with brain tumors. So usually this idiopathic intracranial hypertension, it can cause vision loss, and also it is classically it causes tinnitus that pulses with heartbeat. Meaning you can hear a whooshing sound in your ear together with your heartbeat sound, and they can be having double vision or light flashes. So also ask for any URTI symptom, for example like lacrimation, facial flushing, rhinorrhea, which can be associated with sinus headache. Okay. As I said just now, this pulsatile tinnitus is classically associated with idiopathic intracranial hypertension. Any preceding aura, which is associated with migraine, look for focal neurological deficit, okay, which can be a symptom of brain hemorrhage or CNS infection. Any associated seizure can be associated with either your brain tumor or any space occupying lesions. It can be CNS infections or tumors. Okay. Also ask for past medical history, including if they are, as I said earlier, any exposure to drugs or substance abuse. If the patient has done any recent lumbar punctures, because patients post lumbar punctures, they can be having post lumbar puncture headache. Any patient with immunosuppressive disorders or IV drug use, because it can increase the risk of infection, hypertension, cancer, and any patients who are having coagulopathies or pregnant ladies who are on oral anti-contraceptive or any anticoagulant, they tend to be at high risk of bleeding or venous thrombosis. And family and social history should also be included to ask for any sudden death in family members or any history of aneurysm in family. As for examination, when a patient comes into ED with headache, the first thing is your airway breathing circulation. Check for vital signs. If there's any temperature, their mental status, whether the GCS is full or they are confused, if there's any altered mental status. And then possibly if can do a full neurological examination to look for upper motor neuron or lower motor neuron lesion, as well as gait abnormalities. Maybe if they have some gait abnormalities with some incoordination, it can be associated to cerebellar lesions, any cerebellar tumors. Okay. Look at the scalp, examine for areas of hematomas or swelling or tenderness. And you can also look for, if let's say elderly patient, you can look for ipsilateral temporal artery, try palpating whether it is tender, and usually they have jaw claudication. Temporal mandibular joint are also palpated for tenderness. Look for eye, we can do ophthalmoscope to check for papilloedema, check for the pupillary size, whether they are reactive to light, whether it is similar size bilaterally. Neck flexion, look for Kernick and Brudzinski sign, which is classical of meningismus. Look for cervical spine tenderness as well. So Kernick and Brudzinski sign is one of the famous examination for your meningitis. Kernick is when you ask the patient to flex the hip and also knee at 90 degrees. And when you passively try to extend their knee, they will have pain. It will be associated with pain or limited knee extension. Whereas Brudzinski is more specific for meningitis. So in Brudzinski, you do a passive flexion of patient's neck, and this will cause an active flexion of the knee and hips. So that was for examination. Our diagnosis mainly laboratory, imaging, and also lumbar puncture. So this is the choices of imaging modality taken from the American College of Radiology. So usually any patient who comes in, if you suspect trauma, or any patients with worsened very severe headache, acute severe headache, or new headache with focal neurological deficit, or with any increase in intracranial pressure, you can proceed with a plain CT brain scan. And any patients who we suspect encephalitis or aneurysm or possible vertebral or carotid dissection or suspected temporal arteritis, we can actually proceed with MRI brain with or without contrast. So these are the examples of intracranial hemorrhage. We have extradural, subdural, and subarachnoid that are extraaxial, and intraaxial we have parenchymal hemorrhage. So extradural, just to go through back, so extradural is a lens-like hemorrhage between the skull and also the dura. Usually it is associated with trauma, and the most common artery which is involved in extradural hemorrhage is your middle meningeal artery. And usually this extradural hemorrhage, it cannot cross the suture line, and it is also a neurosurgical emergency that requires urgent surgical intervention. Your subdural hemorrhage is a crescent-shaped hemorrhage, which can actually cross the suture line, okay, unlike in extradural. And usually it can be due to acute injury, or it can develop very insidiously, and more common in elderly and alcoholics. And for subdural hemorrhage, we can divide them into acute, subacute, and also chronic. So, but usually a chronic subdural hemorrhage, usually it will be a hypodense lesion and more than 21 days. If it is more than 3 weeks, usually it appears as hypodense. Whereas if it is an acute subdural hemorrhage, usually it will be a hyperdense lesion, less than 3 days. So as for subarachnoid hemorrhage, is bleeding in your subarachnoid space. So usually it can be due to trauma or non-trauma causes. So if it is a non-trauma cause, usually it's associated with brain aneurysm, for example, like Barry's aneurysm. And then usually for subarachnoid hemorrhage, it can be screened in plain CT scan, and a lumbar puncture can also be diagnostic for subarachnoid hemorrhage, where in your lumbar puncture you can have blood in your CSF, or then yellowish. It can be yellowish, or you can find blood in your CSF, basically. So intraaxial hemorrhage, usually associated with contusions or trauma. It can also be due to some systemic causes, for example, your hypertensive hemorrhages, or hemorrhagic transformation of ischemic stroke, or hemorrhagic infarction, for example, like venous thrombosis. Can also be associated with arteriovenous malformation, or any neoplasm like primary or secondary neoplasm. So usually in hypertensive hemorrhage, patient will develop this intraaxial hemorrhage due to the rupture of microaneurysm of perforating vessels in these regions. And usually the bleeding happens near the basal ganglia region. As for neoplasm, we have primary and also secondary neoplasm. Primary neoplasm is any neoplasm which originates from the brain, and secondary is your metastatic brain tumor. So usually the primary neoplasm, they will have a different pattern of edema from stroke. They have a finger-like projection as shown here, like the yellowish line, and they will have an enhancement with contrast. And if let's say it is a secondary brain neoplasm, they have multiple lesions in the brain parenchyma with vasogenic edema. So this is the post-contrast CT scan where the brain shows enhancing lesion in the right frontal lobe, as shown in the red marker there. And they have extensive vasogenic brain edema with mass effect and also the midline shift. So the end of my slides. So headache is one of the most common acute presentation to ED. The main thing that we have to know is how to differentiate, to pick up on the red flags of headache and to know the low risk patient that can be discharged safely. So our history and examination is the key to evaluation. And usually the mainstay of investigation is your neuroimaging, like CT brain, and TSF is after the ED in medical ward lah mostly. So that's all for my presentation. I have just some journals to share here. This is taken from the American Headache Society. This journal is discussing on the intervention for migraine in emergency department. In this journal, it says that many people presenting to ED in the US for treatment of migraine, and usually the first line treatment given for migraine patient in the US is your metoclopramide, prochlorperazine, and sumatriptan. These three are the first line treatment, but it fails to provide sufficient relief. So in this review, they have discussed the benefits of any IV medication for patients who fail to improve with first-line medication. So the conclusion from the journal was there's no actually evidence-based any second-line treatment for migraine in ED setting. So any patient with migraine who fails to improve with first-line, it is reasonable to just use some IV NSAID or IV acetaminophen. The other journal is discussing on the risk for ischemic stroke and coronary heart disease associated with migraine. And in this journal, it was concluded that usually elderly people with migraine, they are at increased risk for ischemic stroke for some reason, which is not clearly explained. So, primary headaches are usually caused by a combination of genetic and environmental factors, but so far it is postulated that primary headache are caused by a few combination of genetic and environmental factors, but so far there's no genes that have been identified to cause the more common type of primary headache. Okay, so these are my references, and this is the end of the slide. Okay, thank you everyone.
Any question? Okay, thank you, Misha.
Alright.
For the good presentation. Any question to Misha? Ada soalan tak untuk Misha?
Tak tanya, tak tahu ada Misha ke Dr. Mashi. Ada any electrolyte imbalance can cause headache tak? Sebab ada some advertisement kan, medication macam supplement semua tu dia sebut pasal magnesium kan, and calcium supplement to prevent headache lah, especially migraine headache. So ada role tak kalau macam patient datang with headache and then the electrolytes, saya tengok ada magnesium low ke calcium low ke yang can cause headache, and we have to correct lah.
I can listen sulfate ni. Okay, apa ni, siapa tu nama? Mimah. So rasanya kalau macam kata apa, rule of mix up lah. Electrolyte imbalance.
Electrolyte imbalance causing headache.
Kalau macam yang pernah apa ni, yang the literature that I do go through tu, yang extra so called extracranial causes of headaches ni tak adalah specific. They mention regarding electrolyte imbalance, unless ada few yang cakap, for example macam polycythemia yang hypercardia that might contribute to the causes of so-called headache itself. Tapi specifically regarding electrolyte imbalance tu, I didn't come across. I'm not sure either specialist or either our medical officer did come across with any literature or scientific evidence regarding electrolyte imbalance that can lead to headache. Tapi rasanya it depends. Headache itself pun rasanya macam ramai pun, jadi it's subjective interpretation of person to itself. Dan kadang kalau dia kata kadang-kadang dizzy pun dia boleh cakap headache juga, giddy pun boleh cakap headache juga kan. Tapi regarding yang Mimah cakap macam tadi Mimah tanya pasal mix up kan, IV mix up Mimah?
Ya, kalau macam patient mana headache and then kita tengok ada electrolyte imbalance, maksudnya we macam memang kena correct the electrolytes kan, sebab electrolyte tu causing headache kan, dia macam just headache lain lah, depends on the macam differential yang Misha cakap tadi tu.
Rasanya kalau kita tengok the significance of the electrolyte imbalance to itself kot, kalau macam takat reduce macam low normal kan, low normal, it doesn't cause much of concern lah. Kalau memang significantly low, might as well correct the electrolyte imbalance. One more thing, ada one yang I come across with one of the literature that actually mentioned regarding IV magnesium sulfate in managing primary headache that dia mention IV mix up prove less effective lah than yang standard treatment. Okay. Ada yang bagi mix up plus dengan IV Maxilon metoclopramide, but it shows dia tak effective lah, because it reduce the efficacy of the metoclopramide itself. Okay Mimah?
Okay.
Menjawab
Menjawab.
Okay, any question? So basically summary tadi Misha dah mention kan. So the best so kalau kita tengok dekat ED itself ni, kita punya headache ni is one of the so-called common symptoms lah yang datang ke emergency department, especially dekat you punya green case green case. So from kita punya ED approach from the triage, we start from the triage itself lah. Kalau kita tengok, kalau headache ni kita tengok tadi, basically kalau dekat triage kat depan tu, it more concern regarding the pain score of the patient. Kalau tengok pain score dia kalau terlalu tinggi kan, kalau triage officer dah triage sampai pain score 7/10 tu, better the patient at least should be triaged to yellow zone. And then evaluation, kalau dah tengok patient tu, evaluation should start with history, macam tadi Misha cakap kan, history taking, proper history taking. Then you should be able trying to determine if the headache is secondary or primary lah. Okay, and then you should be able to ask the right question to determine if a patient has a secondary headache. Okay, and then majority yang datang dekat kita ni kadang-kadang most of them migraine, cluster headache kan, tension headache, especially masa during PKP last time kan, masa COVID banyak-banyak tu patient PKP tak kerja kan. Banyak patient kita dapat dekat observation tu, banyak yang sebenarnya tension headache, tak boleh kerja lah apa semua kan. It's just that you just give some pain management, observe patient. Okay, and then nak add on regarding kalau nak ingat the mnemonic of red flags in headache ada yang kita ingat pasal yang ada yang mention, literature mention regarding SNOOP, S-N-O-O-P. S is systemic symptoms, for example, fever, chills and rigors, weight loss, having HIV infection ke. N is for neurological signs or symptoms, for example, confusion, change in mental status, seizure. O is onset is most of the time acute or sudden. Another O is older patients, more than 50-year-old with first new onset of headache or progressively having a headache. And the last one is P. P is previous headache history ataupun first headache or different change of pattern in headache. Okay. So another thing yang I would like to add on is headache in children. Headache in children, another recommendation to show that it is red flags bila budak-budak lagi susah kan. Susah kita nak evaluate, nak assess what kind of headache. Kadang-kadang kalau macam sekarang ni lagi kan skor main gadget, handphone pun sudah sakit kepala kan. So it's very difficult lah. But yang you all should be pay attention of in children. Headache in children is headache when it is associated on awakening, bangun tidur ataupun hospital location. Okay, so that kind of headache required further evaluation and imaging. Okay, same goes to your pregnancy. Janganlah kata kalau pregnancy tu kalau datang dengan headache tu because of it goes same as your punya red flags tu juga kan. Kalau ada such criteria that indicated for you to proceed with CT imaging, sebab dia pregnant tak mau buat CT kan, and then patient is actually having hemorrhage. Okay, that kind of patient, kalau macam patient yang memang pregnant required CT, you should proceed lah. Sebab the radiation itself is actually less than 100 kan. Less than 100 lah CT scan. Okay, so others, the pain management, the diagnosis is accordingly to your initial diagnosis, your tentative diagnosis. And then neuroimaging is still the gold standard for him. Because the gold standard, kalau you memang required patient got red flags, you still have to proceed with CT scan examination. And then most of the time patient yang datang dengan primary headache primary headache tu you punya pain management lah, most of kita bagi pain management kalau ikut American Headache Society American Headache Society, they mention that do not prescribe opioids as the first line. So tadi macam Misha pun cakap tadi kan, Misha cakap tadi tak cakap so headache especially primary headache ataupun you unspecified headache patient yang tak ada reflex. Dunia nak kata migraine susah kan first presentation, tapi the history is more towards a primary headache. So what you can do is you can actually administer itu dah NSAID lah, bagi NSAID dulu lah. NSAID plus you can plus minus lah, boleh bagi plus minus your metoclopramide, you punya dopamine antagonist antiemetics. Certain study kata dia bagi NSAID saja pun patient resolve. Certain literature said you can combine and then that's why we have a rule of observation in headache lah, because semua not all patient come with headache you terus nak buat CT unless patient ada reflex lah. Okay, kalau you boleh diagnose the history is actually migraine primary headache migraine tu, jadi you don't have to do CT lah. Kita ada rule of observation. Lepas bagi you punya standard treatment of NSAID plus your so-called. Ya, kat sini pun kita bukan ada high-fi punya NSAID kan. Dr. Rohayu dah try minta banyak dah add on NSAID. Apart from kita punya standard, kita ada apa Panadol, kita ada apa diclofenac. So kita tak dapat lagi lah from yang example yang lebih hebat. Okay, so if during the observation, if the patient still have persistent headache,
Itu masih tak dengar.
Itu masih left.
Okay, dengar.
Dengar.
Okay. So pain score is very important. Pain score is very important. Not specifically when you are dealing with patient with headache. Semua patient lah dengan pain. So because that is going to be your so-called guides for you. Either you want to add on others medication, or you should proceed with neuroimaging lah ini patient in headache. Kalau patient tu at least turun daripada pain score, first initial pain score turun 4 tu, that's mean 3-4 lah kan. That's mean your treatment is actually jalan lah. So kalau static itu je, might as well you nak proceed dengan neuroimaging. Dr. Rohayu nak cerita sikit pasal pain.
Okay nah. Assalamualaikum, good morning. Okay, so pain score is very important. Okay, memang kita masukkan compulsory kan dalam you punya clinical notes, you kena klik pain score baru you boleh record sign kan. Tapi kadang-kadang most of us memang buat tu purposely untuk nak boleh sign lah. Kan you tak betul-betul assess the pain score. So important lah, setiap orang please assess properly dia punya pain score. Kalau tak ada pain score, tak apalah, kosong lah kan. Sometimes patient ada pain score tapi tak ada pain. But nobody try nak assess dia punya pain score. So as we know pain score 0 sampai 10 kan. So actually pain score ni dia membantu dalam kita treat the patient. Macam Dr. Mashi mention, you nak tengok you punya pain tu, you punya medication ataupun management tu efektif ke tak. Number 2 is kalau patient tu ada persistent pain, meaning that you have to search what is the underlying problem. Mesti ada patologi yang menyebabkan patient still ada persistent pain. Kan? So kalau pain score less than 4, maksudnya 1 to 3 tu kalau patient dah improving, pain score less than 4, you able to discharge the patient with the medication. Okay? Kalau persistently pain, maybe you should need input daripada EP, ataupun you need to admit the patient lah. EP, KIV for admission lah. Kalau persistent pain, you still search for underlying cause, you buat neuroimaging pun tak apa. So maybe this patient require admission. Okay. So kalau kata you bagi pain management ni yang saya duk tengok ni, pain management. So basically dia boleh categorize pain score tu pada mild, moderate dengan severe. So kalau mild tu you boleh bagi yang simple-simple je, PCN, NSAID apa semua. Yang moderate tu 4 to 6 tu you combine. Usually you combine the pain the opioid and NSAID. Sebab opioid ni dia punya function dia untuk blunt you punya perception of pain kan, tapi dia tak ada anti-inflammatory punya effect. So maybe boleh combine opioid plus NSAID. Kalau you tengok pain score, pain ladder, acute pain management, the pain ladder ni. So yang ni KKM punya so you boleh combine. Kalau pain score tu more than 7, most probably kena bagi morphine lah. Kan selalu kita takut nak bagi morphine. Tapi kalau severe pain, yes, there is a rule of morphine. Tapi kalau you bagi morphine tu, you kena endorse dalam ada morphine protocol yang kita punya notes tu. You type morphine tu, dia ada naik morphine protocol. So you kena tulis. Sebab apa yang ni nak tunjukkan, bukan nak tunjukkan. Maksudnya ED, nanti kalau bila kita minta medication pun nampak kita usage of the morphine tu. Okay? So kalau nak treat tu mainly the best is you treat accordingly ikut dia punya pain score. So yang ni is only for acute punya pain lah. Kalau patient yang memang duk chronic pain selalunya dia tak jalan lah. Chronic pain selalunya tak jalan only on NSAID opioid. So kalau yang chronic pain ni maybe dia kena ada follow up. Tapi dekat Sungai Petani tak ada INS tak ada klinik untuk chronic pain. So selalunya kita memang sama ada KK ataupun yang kalau dia teruk-teruk sangat apa dia pakai refer to HSP lah. Sebab kita tak ada chronic pain punya NS tak ada chronic pain punya klinik.
Okay, Dr. Rohayu is Dr. just now explain regarding pain management as a whole. Kalau regarding headache ni, okay, banyak literature, banyak study dia memang against opioids as the first line of treatment in headache. Okay, as I did mention just now, the first line is still your NSAID. Okay, NSAID ke plus minus you boleh bagi you punya dopamine antagonist, antiemetics lah. Kat sini kita ada you punya metoclopramide lah. Okay, and then ada yang yang the second line they still propose for you to give IV NSAID, which is kita tak ada pun dekat sini lah. Kita tak ada lah dekat ED kita ni IV NSAID tu. IV NSAID. So yang tu kalau memang dah tak boleh. Okay, yang tak boleh sangat yang first dose dia dah bagi dah. Dia punya NSAID plus antiemetics. Most of the time kalau acute patient yang primary headache ni, most of the time dia resolve aja. Soalnya yang degil ni is chronic lah, chronic headache ni. Ataupun patient memang ada reflex. Okay, memang ada brain pathology. Okay, so still don't describe opioid as a first line of pain management in patient with headache. Okay, so any other question? Okay dah? Ada soalan lain? Okay. 1, 2, 3, 4, 5. Okay, bye-bye.
Thank you, Doctor.
Okay. Okay, bye. Thank you, Misha. Thank you,
Thank you, Doctor.
everyone. Okay, bye.
Thank you, everyone. Bye.